So now, when to offer information to a woman with gestational diabetes? First of all, the information about all of these things should be provided to these women from adolescence, and it should be provided at each contact with the diabetic care team. Document about the plans of pregnancy and about the contraception used at each contact with the diabetes care team from adolescence. Right? Ensure that the information that you're providing should be provided in a supportive environment, and encourage the involvement of partners and family members in this discussion. Now, education and advice: offer women with diabetes who are planning to become pregnant a structured education program as soon as possible if they have not received one, and offer women with diabetes who are planning to become pregnant preconception care and advice before discontinuing their contraception. Retinal assessment: all females who are diabetic and want to become pregnant, they should be offered retinal assessment as their at their first appointment in the preconception period if it is not done within the last 6 months, and after that it should be repeated annually if the first one is normal, and it should be done by the help of this mydriasis with a tropicamide drug. Defer the rapid optimization of the blood glucose levels until the assessment, the retinal assessment, and the treatment for it has been completed. Now we'll start with the gestational diabetes mellitus. So basically, gestational diabetes mellitus will have the risk assessment, then the treatment, and the intervention. There are three main things in this. Risk assessment. Well, those women who have diabetes mellitus, they should be provided certain information so that they can make an informed decision about the risk assessment and testing for gestational diabetes. Explain to the woman that there is a response seen in women with gestational diabetes to the diet and exercise alone, and that the majority of the patients who do not respond to diet and exercise, they will have the use of oral glucose lowering therapy or insulin. If gestational diabetes mellitus is not detected and controlled, there is a small increased risk of serious complications or birth complications such as shoulder dystocia, the most common, right? And that if the woman is diagnosed with gestational diabetes mellitus, it will lead to increased monitoring and may lead to increased intervention during both pregnancy and labor. Okay, there are certain important risk factors for diagnosing gestational diabetes mellitus. Among these, the most important one is previous history of GDM. Then we have previous history of macrosomia, that is 4.5 kg or more. Family history is important in the first degree relatives, those females who are having a BMI of more than 30 kg per meter square, and those who belong to a minority ethnicity, right? So if any female is having a previous history of GDM, she should have a GTT at the booking visit as well as on the 24 to 28 weeks if the previous GTT was found normal. And for all the other risk factors, the GTT should be done at 24 to 28 weeks, right? And this should be a 2-hour 74 gram OGTT test. The levels for diagnosing GDM are, it is very important, that is the fasting levels should be 5.6 or the 2-hour glucose level should be 7.8. So the easiest way to remember this is 5, 6, 7, 8, right? Now, any female who is diagnosed with gestational diabetes mellitus during this pregnancy should be offered a review with the Joint Diabetes Mellitus and Antenatal Clinic within a 1-week period, and then inform the primary care team that the patient is having diabetes mellitus, right? Okay, so the interventions required are that explain to the woman with gestational diabetes about the implications, both short and long term, for the diagnosis of her and her baby, that good blood glucose control level throughout pregnancy will reduce the level of fetal macrosomia, trauma during birth for her and the baby, induction of labor and the rate of cesarean sections, neonatal hypoglycemia and perinatal death. Then teach the woman with gestational diabetes mellitus about self-monitoring of blood glucose levels, and that she should use the same capillary plasma glucose target levels for women with gestational diabetes as for women with pre-existing diabetes mellitus. The important values are that her fasting blood glucose levels should be between 5.3 millimole per liter, and 1 hour should be 7.8 and 2 hours should be 6.4 millimole per liter. So the easy way to remember is that fasting glucose 5.3 millimole per liter, increase 1 digit from 5, so that makes it 6, and 1 digit from 3, that makes it 4 at the 2 hour level, so that makes it 6.4 millimole per liter. and then the figures in between, that is 5364, but 7.8 are remaining. So the 1 hour plasma glucose will be 7.8 millimole per liter. Then the blood glucose lowering agents should depend upon the blood glucose profile and also upon the preferences of the patients. The woman should replace high glycemic index foods with the low glycemic index foods. Refer all the women who are diagnosed with gestational diabetes mellitus to a dietitian. The important point is that whenever the plasma glucose level at the diagnosis is less than 7 millimole per liter, you start her on diet or exercise changes. If there is no improvement within a 1 week period, you start on metformin. And if still there is no improvement, you add insulin. Or if the woman is not accepting metformin or the metformin is contraindicated, then you start her directly on the insulin. Number second, if the plasma glucose levels are more than 7 millimole per liter at the diagnosis, you start insulin immediately. Or even if the plasma glucose levels are between 6 to 6.9 millimole per liter, but these are associated with complications like macrosomia and polyhydramnias, then also you have to start it with insulin immediately. Then you can also consider glibenclamide if the woman is not accepting metformin, or if there is no control of plasma glucose levels seen with metformin and the insulin therapy is declined by these patients.